എല്ലാ വ്യാഴാഴ്ചയും അങ്ങ് പുതിയ പുതിയ കാര്യങ്ങൾ ഞങ്ങളെ കേൾപ്പിക്കുകയും അതിനുവേണ്ടി അവിടുത്തെ മക്കളെ ഒരുക്കുകയും ചെയ്തതുപോലെ ഇന്നും OPGയും സൈക്യാട്രിയും രണ്ട് ഡിപ്പാർട്ട്മെൻറ്റുകളുമായിട്ട് എടുത്തായിട്ടുള്ള എല്ലാ എഫേർട്ടുകളെയും ഇന്ന് അത് ഞങ്ങൾ കേൾക്കുവാനും കാണുവാനും അത് ഞങ്ങൾക്കൊക്കെ ഒരു അനുഗ്രഹമായി തീരുവാനും ഞങ്ങളെ സഹായിക്കണമേ. ഇതിൻ്റെ മുൻപിൽ നിൽക്കുന്നതായിട്ടുള്ള എല്ലാ ഡോക്ടേഴ്സും മറ്റുള്ള സ്റ്റാഫുകളെയും അനുഗ്രഹിക്കണം. ഇന്നത്തെ ഈ പ്രോഗ്രാമിൽ വന്നു ചേർന്നിരിക്കുന്നവരും വരാൻ ആഗ്രഹിക്കുന്നവരും ഒരുമിച്ച് അത് അനുഗ്രഹം പ്രാപിപ്പാൻ ദൈവം ഞങ്ങളെ സഹായിച്ചാട്ടെ. പ്രാർത്ഥന കടനായി നന്ദി. ഞങ്ങളുടെ കർത്താവും ഞങ്ങളുടെ രക്ഷിതാവുമായ യേശു ക്രിസ്തുവിൻ നാമത്തിൽ തന്നെ. ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
It's been some time that the Department of Psychiatry and OBG been working together to start specialized services for women of childbearing age. Chitra Madam has been always inspiring us, and George Chandy sir has always been telling us to start new services which would be the need of the hour for our patients at this part of the world. So we have a lot of patients who have psychological difficulties and neurobiological changes which happen during pregnancy, which would precipitate disorders, psychological conflicts that would go unnoticed. So today we have 3 wonderful speakers. Without spoiling the content, I'm handing over the first presentation to Dr. Aparna, Assistant Professor, Department of Psychiatry, to start with.
A very good morning to one and all. So today we've gathered here to discuss the perspective of the scope of perinatal mental health services. So it's Advanced Maternal Mental Health Assistance. So that's the acronym AMMA stands for. So that's what we are going to look at today. So an introduction, a background of the problem, need for the services, how we are going to go about a pathway of care. Shortly about the mother-baby units which are functioning in other parts of the world. There are some unmet needs in the services which we will shortly discuss. Objectives of the clinic, pathway of the care, and how we are going about the training and screening purposes. So before we begin, let me tell you the story of a patient, Mrs. Y. So Mrs. Y had presented to the psychiatry OPD at PCMCH a year ago with the chief complaints of suspicion, irritability, and decreased sleep. So she used to be suspicious about her husband is having another relationship with a lady, and she was also saying that her neighboring lady has put up cameras in her room, in her apartment, to spy on her. And she also says that her phone is being tracked. She doesn't speak over phone. Whenever she speaks, whenever the others in the family speaks loudly, he'll tell them to close the windows, speak softly and all. So that was the presenting complaints, and she was diagnosed to have a psychotic illness. So that time she was having a daughter who was 5-year-old, and she came with her husband and her mother and mother-in-law. So we started her on olanzapine, which is a second generation antipsychotic, and by about 20 milligram we got a good response. And in view of depressive symptoms, we started her on escitalopram as well, which is an SSRI. So, and one more thing she had was that she had severe emotionally unstable personality trait, which is otherwise known as borderline personality traits. The key features of which is emotional outbursts, anger outbursts, unable to control emotions, emotional dysregulation, that is what we say, and frequent thoughts about self-harm and deliberate self-harm attempts. So for this reason, she had to be admitted twice in the IP facility in view of severe suicidal thoughts and risk of self-harm. So that going on, after a period of 6 months, her symptoms were remitted well, and she continued follow-up in both psychiatry and psychotherapy. So, and there was ongoing issues, interpersonal issues between her husband, family, in-laws in between. So we were dealing with it. So she underwent follow-up with both the departments of psychiatry and psychology. So around May 2025, her UPT turned positive, and she was pregnant with her second baby. So the husband and the patient were speculative about continuing medications while she was pregnant. So we had a discussion with the husband and the patient And since they were not very happy to continue the medication, we discussed the pros and cons with them, and the medication was tapered and stopped. Anyway, she didn't have any symptoms that time. However, she was told to continue regular follow-up in connection with her antenatal checkup. So while she was coming to visit the Department of OBG for her antenatal checkups, she was visiting us also, and we were seeing her regularly. Something like a wait and watch approach. So around 14 weeks of amenorrhea, again she developed psychotic symptoms, a delusion of persecuted delusions, delusion of reference, along with severe depressive symptoms, and this interpersonal ongoing conflict with her husband. So we had to restart her antipsychotic, which was titrated up to 5 milligram, and she was advised to undergo regular follow-up visits and with analysis. Right now, currently she is in her 22 weeks period of gestation, and for as of now, mother and baby are well. She's on her olanzapine, and there are no symptoms reported. So that said, we'll come back to her story at the end of this discussion. So let me tell you a few words about the importance of perinatal mental health. So that's one of perinatal psychiatric disorders are one of the most underdiagnosed, untreated, and I would say denied disabilities. So WHO defines postnatal depression as a special state of mental health disorder and a variant of depression. So here there are two vulnerable sets of population at the most vulnerable period of their life, the mother and the infant. So in both this group of people, it can have both short term as well as long term complications, both physical and psychological. So that's the importance of mental health during the postnatal, antenatal, and perinatal period. So worldwide, the global burden of pregnant women being mentally ill is 10%, and it's 13% in those who have just given birth. So in developing countries like ours, it is even more. It's like 15.6 and 19.8 respectively, antenatal and postnatal. So the most dreaded or most serious complications include maternal suicide and even more infanticide. So, and like we said just now, it affects the long-term well-being of the mother as well as the baby. Like John Bowlby proposed attachment theory. The mother-baby bonding starts right in the womb, and outside after the delivery, it's only a continuation of whatever has happened inside the uterus. So if the mother's mental or physical health is not proper, it affects the baby as well. So that background, I would like to invite your attention to a more important problem, that is suicide as a leading cause of maternal mortality. So it is a recent finding that suicide is a rising cause of maternal mortality. It's over 20% now, and about 2/3 to 3/4 of the suicides occur in the first 1 year postpartum, which is the most vulnerable period for a mother. Among the women who attended obstetric care, the suicide ideations was found. Suicide ideation means the intent to take one's life. It was around 2 to 5%, and those who were already diagnosed with the depressive disorder and is on treatment, it was 5 to 14%, and those mothers whose babies were in NICU, it was around 9%. And another belief and understanding previously was there is a protective effect for pregnancy and childbirth against suicide, because when the mother has a baby in her hand, she has got a new responsibility. It kind of protects her against the thoughts of ending one's life or hurting oneself. So right now the current study tells us that this protective effect is not as much as what it was thought to be previously. So the protective effect of pregnancy against suicide is less than what it was previously suggested. So coming about the risk factors of suicide in the postnatal period, pretty much the same for any patient who has got a suicidal risk. So that is, first thing is, the most consistent finding is a underlying psychiatric disorder. Most commonly depressive disorders, others could be anxiety, adjustment disorders, post-traumatic stress disorder, personality disorders, bipolar affective disorder, and schizophrenia. Past history of suicidal behavior or suicidal ideation. A diagnosed postpartum mental illness carries 6.2% higher risk than who has not been diagnosed previously. Other risk factors could be young age of the mother, unmarried mothers, unplanned pregnancies or an unwanted baby, marital dissatisfaction, family conflict, social disadvantages, financial instability, an illness or an anomaly with the newborn, adverse pregnancy outcomes, obstetric complications and substance use in the mother. Yeah. Now, coming to the most serious, most dreaded, and most tragic complication of a postnatal psychiatric illness, that is infanticide. So, every mother who's diagnosed to have a postnatal psychiatric illness carries a 4% risk of infanticide, most consistently found with people who have chronic schizophrenia. Other risk factors include acute psychosis, unwanted pregnancy, and altruistic murder. Altruistic murder means the mother feels my baby is not fit for this unhappy, unhealthy world. The world is not right for her, so I might as well take her with me. So that could be a psychotic thought. The mother thinks that some negative energy is trying to harm her baby, or the baby may not live or thrive without her, so decides to take the baby with her. So that is altruistic murder or altruistic suicide. Women suffering from this is one dangerous finding, I would say. People who are suffering from non-psychotic depression or depressed mothers may not communicate their thoughts about infanticide, may not disclose the thoughts unless you ask actively. So that is about infanticide. Now, the Indian scenario. So this part of the world has some unique challenges, like the stigma associated with the psychiatric illness, unplanned pregnancy, the gender of the child is a problem in many cultures, and many of the postpartum difficulties, like the mother feels fatigued, the mother has got decreased sleep, the mother is feeling sad. All these things are most of the times perceived as normal and sometimes dismissed away, saying that we all had children. Okay, we all had children. We all went through the same. What is new with you? What is wrong with you? So that's those symptoms may be sometimes perceived and dismissed away as normal. So postpartum depression is estimated to be 22% in India, and the prevalence of antepartum depression ranges from 9.18% to 65%. In southern part of India, this was a study conducted in Nimhans. So they found out in southern part of India, it is 26%. So we move on to the current scenario. So what have we done for this? Unfortunately, India still doesn't have a national policy incorporating maternal mental health also. It lacks an integration with the general physical care. Now, the stigma and the cultural barriers stand a major block to seeking help. There are some promising initiatives, amongst which is the Mother Baby Unit at National Institute of Mental Health and Neurosciences, Bengaluru. We'll just see how that functions. So the idea of a mentally ill mother being admitted with her infant was proposed by Thomas Main in 1948 at Kessel Hospital, England. So MBU, Mother Baby Unit, is an inpatient service which has at least 4 beds where the mother and baby is admitted with a bystander, where they encourage feeding. The neonatal services are done, the immunization schedules and vaccination schedules are consulted for specific interventions for parenting, psychotherapies, enhanced mother-baby bonding, and psychoeducation. So basically, it is integrated with the mental health, gynecological, and neonatological services. So 75 to 80% of mothers who have been admitted or who has been taken care of in a mother-baby unit reports better outcomes. So that is the idea of a mother-baby unit. So now we'll see briefly how it functions at Nimans. So the first MBU or the mother-baby unit started at Nimans. It was in July 2004. It is both OP and IP services. It includes a multidisciplinary team. It includes a psychiatrist, a psychiatric social worker, a psychologist, psychiatric nurse, and lactation and pediatric support. So they do an assessment before the admission. They do an assessment which is initial risk assessment for the mother and baby. That is first MB, formal initial risk assessment for the mother and baby. They assess for any psychological risk factors. NIMBUS is Nimhans Mother Behavior Scale Under Stress, and Postnatal Bonding Questionnaire, that is PBQ. So these are the different tools they use to assess the maternal behavior while the baby and mother is being taken care of in the mother behavioral unit. And now the mothers and infants, when they are admitted with a family member, preferably a woman, in keeping with the local cultural traditions. And all infants are referred to the pediatric facility for consultation about feeding and immunization, psychoeducation sessions, specific interventions for the spouse and the mother, caregiving concerns are addressed, group sessions are given, and of course, if there is any documented psychiatric illness, that is being treated. Yeah. So, despite this initiatives, there are some unmet needs in this part of the world, which includes lack of a comprehensive national policy, treatment gap, which the reason for the one of the main reasons for which is the stigma associated with the mental illness. Lack of services is a reason. Geographical barriers, lack of trained personnel, and another important point is that an idea of self harm is not routinely screened in many of the OP visits. So, there is a popular myth that when you ask a person about suicidal ideation, when you actively ask somebody whether you have thoughts of hurting yourself, maybe it will trigger their thought to end their life, or it maybe it will trigger a suicidal thought, which is a misconception. On the contrary, we must ask them about any such thoughts. Maybe you are the last person, maybe they'll open up, and there we are saving one, not one, two lives, the mothers and the infants. Yeah. So this is what we intend to do at the perinatal clinic at BCMCH: the screening of antepartum and postpartum psychiatric disorders, the diagnosis, management, and treatment, integrating in collaboration with the Department of Obstetrics and Gynecology, and continued care and follow up, psychoeducating and ensure their compliance to both therapy and treatment. So this is the proposed pathway of care which we are intending to go about with these patients. So first, the referrals. The referrals can be self, because what we are trying to do is one of us will go to the antenatal classes that is taking place at the Department of OBG. We will sensitize the mothers, going to be mothers, about the importance of mental health. Another referral sources from the consultants, obstetric consultants, which we are already getting some of them. We'll only strengthen that referral pathway, and then of course IP patients who are already admitted, whoever finds to be having some sort of difficulty can approach us. Another thing is we're planning to train the nursing staff about screening people, antenatal people, for any mental health symptoms with a screening tool. I'll talk about it. And once they're assessed, once they're screened, they'll be sent to the clinic where they'll be assessed for any specific psychiatric disorders, and accordingly discharge, a treatment plan as will be formulated. So this is the pathway of care which you are planning to go about. Yeah. So now a few words about the screening. So antepartum mothers, like we said, one of us will go to the antenatal classes and talk to them about how important mental health is, and sensitize them about the red flag signs of mental health illness. The nursing staff will be sensitized about the tools for screening. We have already spoken about in the Department of OBG with Fathima. So these are the screening questionnaires we are planning to use. So patient health questionnaire PHQ-2 is derived from a much more comprehensive PHQ-9. It serves as a first step approach to identify individuals who may need further evaluation. So a score more than 3 suggests a high likelihood of depression. So this is the scale. It has got 2 questions and a rating ranging from 0 to 3. So it has little interest or pleasure in doing things, and feeling down, depressed, or hopeless over a period of last 2 weeks. So it's a very easily administered scale. So that is one. And another thing is distress thermometer. It is like something like a visual analog scale. So the patients can mark the level of their distress on this thermometer over here. So ranging from 0 to 10. And the right side, there is a list of problems. So they can just tick mark what sort of problem they are facing right now. Could be family distress, could be social isolation, could be depressive illness, could be childcare, whatever they feel is their concern. So these are the 2 tools which we are intending to use as screening tools. Now the red flag signs. So recent change in the mental state or behavior, rapidly changing mental state, new thoughts about self-harm, pervasive guilt or hopelessness, evidence of a psychotic illness like hallucinations or delusions, repeatedly, these symptoms happening repeatedly, and new or persistent expressions of incompetency in taking care of the baby or estranged from the infant. So these are the red flag signs which we are going to look for, and this is how we are going to assess the patient for postpartum depression, depressive symptoms. That is, this is Edinburgh Postnatal Depression Scale. It is a 10-item self-report questionnaire. It's used to screen for postpartum depression in new mothers and during pregnancy. So there are other scales as well, like PSAS, postpartum stress and anxiety scale. Then there is mood disorder questionnaire, So these are a few tools which are planning to assist the patients. Now, what the clinic offers. The scope of services include clinical assessment and diagnosis of mental illness, treatment and management, both pharmacotherapy and psychotherapy, preconceptional counseling, medication planning in view of pregnancy and lactation, mental health services for a couple who are trying to conceive or somebody who's taking infertility treatment, crisis intervention and referrals, training and capacity building and research. So this is our team. So this is what the team will consist of: the psychiatrist, the obstetrician, the clinical psychologist, obstetric nurse, and a psychiatric social worker. So with that, I conclude my presentation. Now let us come back to the story of Mrs. Y. So Mrs. Y's case is a classic example of how mental illness affects maternal well-being. So her family and her husband had speculations about her illness and her treatment and her medications as well. And in fact, her husband asked us whether we want to continue, whether they can terminate the pregnancy, because he was speculative about her health and her being able to look after the baby along, especially when she had an elder child. So they were psychoeducated and informed regarding the treatment options and that the medications are safe and effective during pregnancy. Thanks to this teamwork, she is in her 22nd week now, both mother and baby well so far. So with that, I would like to conclude my presentation, and may I invite Dr. Arunima ma'am to give us a perspective about the obstetric part of the postpartum mental health disorders. Thank you.
Good morning, everybody. Respected seniors, friends, and dear students. So I'll be speaking on an obstetrician point of view. I'll title it as Recognizing the Unheard Cry, the Hidden Struggles of Postpartum Depression. The obstetrician is actually privileged in bringing out the newborn to the world. And simultaneously, there's a birth of a mother happening. Actually, the struggles has happened not just 12 hours before. Rather, the struggle begins right from the conception onwards. The moment she's diagnosed with pregnancy, she starts taking care of herself. There's a lot of physical changes happening, mental changes happening, and she prepares herself to become a mother. And in the first trimester, yes, she has lots of changes and bodily changes. Along with that, she has altered taste, smell, nausea, vomiting. In the third trimester, again, because of the abdominal distension, she can't sleep properly, she can eat properly, and there are episodes of abdominal pain. And later on, finally, the day which she's frightened from the day one on pregnancy. That's a labor. As the term suggests, it's actually the term, the the term is correct in every sense. It's a labor. And after labor, there's a struggle, and no, she has sleepless nights with a newborn. So the struggle is continuing. So it's actually a stressful period right from the onset of pregnancy. So this is actually pushing a lady into a phase of depression, because there are physical changes which is to an extent they are worried about. And we get the question whether madam eniki tirichu parayapole avan pattumo. This is a question which everybody puts forth. So we assure them, because that assurance is very important. So I'll rather say, when a patient in a postpartum period has some sort of difficulties, people around her should be aware of the situation so that they bring the patient to a medical facility. Most of the family members are unaware. They've unheard of such a terminology called postpartum depression. Actually, the root cause, you can trace it. The symptoms can be traced even in the antenatal period. But because of the ignorance, people don't say this as a complaint. So I'd rather say that it's an unheard or an unrecognized, untreated, and underestimated condition. Now, so it's a moderate to severe depression that affects a woman after the childbirth that lasts longer than just the baby blues and making it difficult to take care of the baby. So the depressive symptoms has been there during the pregnancy, and it extends to the postpartum period. So definitely, as Dr. Aparna has said, the magnitude is actually underestimated. It can extend up to 26% in India. And what the obstetrician feels is, the worrying factor as an obstetrician is the increasing rate of suicides. So about 2 years back, it was actually the second most common cause of maternal mortality. We have a confidential review of maternal deaths, which happens every year, and every maternal death will be audited. And they bring out the methods by which it could have been prevented. The steps will be well elaborated. So you can see this is the cases of suicides. You can see the trend is on an increase. So in 2004, there were only 3 maternal deaths. I don't know whether it is the actual number, but it has increased to around 19. The maximum number which is mentioned is actually 19, which happened in 2019 and 2021. Later on, in 2024, the number is 14. And in 2025, up to August, it's 3. That's in Kerala. It's Kerala alone. CRMT is in Kerala. It's initiated by Kerala Federation of Obstetrics and Gynecology. So I'd rather say that this is a need of the hour. That's a timely recognition is very important, that it can change the trajectory of both the mother and the child's life, because it has got an impact on it has a far an impact which reaches beyond just the mother and the baby, and it affects the bonding, breastfeeding, as well as the infant development. And it is noted that there is an increased marital conflict, as well as it affects the family well-being. So as Dr. Aparna has said, there are lots of red flag signs which has to be picked up. And as obstetricians, we are actually familiar with the patient. And even the patient is much more familiar with us, because we have been seeing them for the last almost 9 months. So they can open up to us. So you have to evaluate whether any behavioral changes is there. Obviously, obvious behavioral changes happen to the patient or not. There is an intense sadness, or mood swings, or irritability, uncontrolled crying, insomnia, excessive sleeping, loss of appetite, anxiety, fatigue, and difficulty in bonding with the baby, and panic attacks, or the fear of harming herself and even the mother, and if the baby is important. So as Dr. Aparna has said, there are screening tools which we take is actually the Edinburgh Postnatal Depression Scale, and Dr. Fathima is actually conducting a study on it as a thesis. It's a thesis, and she'll be presenting shortly. And what does we do? Yeah, as an obstetrician, we are actually screen the patient. So we get to screen the patient right from the moment she has her first visit with us, because the first visit we take a detailed history, and any likelihood of developing depression or any history which is suggestive of depression should be picked up. And so early identification and risk stratification is very important. So as I told, screen for any past psychiatric history, any antenatal anxiety, depression, domestic stress, poor social support, and screening the screening tool, and always include the family members during the antenatal visit, because that's very, very important. You get to know who are all there, the family, how are the family members are supportive. And a proper counseling session should be there. So that will normalize the emotional fluctuations to an extent, and the red flag signs will be picked up as early as possible. And you have to give a proper counseling regarding what is going to happen in the pregnancy, what is going to happen during the delivery, during the postpartum period, and breastfeeding. Everything has to be explained and counseled in detail to the patient. That will reduce the postpartum depression. And the proper antenatal classes are very important. And you have to stress on the lifestyle and the sleep hygiene. Patient has to get good sleep, and she has to have some sort of exercise. That's mandatory. And adequate rest and adequate nutrition is mandatory. Now the trend is, once the patient is diagnosed with pregnancy, either she takes a leave or she resigns from the job and sits at home, and she's in complete rest without any physical work. So that is not a good trend which is happening. Rather, she can continue with the routines as this is a physiological condition. And there should be a good social support network around her. And intrapartum period is solely an obstetrician's responsibility. It's not just obstetrician, and the nursing department also has a good role in it. So you have to respect the patient who is there in labor, because this is a time when the patient is in agony, and this is a time when the patient was afraid from day one of pregnancy. So be compassionate to the patient and have a good communication with the patient as well as a bystander. We have to entertain a labor companion when the patient is labor, because that will alleviate a lot of anxiety, because patient is much more comfortable with anybody amongst themselves, the relatives. And the best partner is actually the husband, because he has to see the struggle which the wife is passing through. And the next is a postnatal period. Postnatal period, yes, obviously the counseling regarding the postnatal period as well as the breastfeeding is very important. And psychological support by the teams, the nursing team, as well as the NICU, everything, every department is very important. So in cases of high-risk patients, prophylactic psychotherapy is important, especially in patients with history of prior depression. And there should be a good discussion with the psychiatrist whether to continue the patient, depending on the risk factor, whether to continue the patient with antidepressants or to stop it or to adjust the dosage. And the family members should be made aware of all the red flag signs. So what is happening currently in our department? Yes, we have already initiated it. For years, we have been doing the same thing. So we have regular antenatal classes. We have 4 classes in a week, and we distribute pamphlets in which the antenatal services, the antenatal period, things to take care, and the postnatal is all mentioned in the pamphlets. And there will be question and answer sessions which are conducted by junior residents, and a patient has to attend at least 2 antenatal classes before she gets into labor. And patients as well as bystanders are given a chance to familiarize with the labor room, and as well as our nursing care team, so that they are much more comfortable with the situation, and they are familiarized. And in the postpartum period, again, we give lots of counseling sessions, and breastfeeding counseling was also given. Question and answer sessions are there. And as Dr. Aparna said, the clinics will be set up in the psychiatry OPD because of the lack of space in our OBG department. And we usually have a telecontact, that is teletherapy, that is for every patient who is in our department, especially with a medical disorder like hypertension or diabetes, who are discharged from our side, is usually called back over phone, asked about her blood pressure or blood sugar values, and the doses are adjusted. So such a facility is offered even for a postnatal patient, and her mental well-being and physical well-being is inquired about. So that is, I think, a good initiative which was taken years back. So now there's already a peer support group which is happening in our hospital. That's peer support group for preterm mothers, especially women who had delivery removed from term, like around 26 or 28 weeks, and they had to stay in the hospital for around 2 months for the sake of baby. Those patients are more prone for depression, and hence there is a WhatsApp group amongst themselves, and they get to know each other, and they have a rapport amongst themselves. So there's socially they're active, and there's a continued holistic approach which is happening, and we have best counselors in our hospital for the mental health and the physical health. Counseling is happening. One is Thomas Sachin. We have known from the patients itself that after his counseling that the patient has such a positive response. And even our own sister, Ansama sister, we have a wonderful nursing care team. I think this is a time that I need to appreciate both of them because they do a wonderful job for the postnatal patients. And yes, there are challenges which we face, definitely. Patients who are in the private rooms do not respond to our any types of questionnaires. I don't know what is the reason. We are actually concerned about the physical and mental health, but patients are not that responsive in the private room. So, and any issues regarding such a condition should be handled by both the departments together. And the outcome, what we anticipate, is actually the reduction of maternal death because of suicide or even attempted suicide. There should not be even a near miss case. So what the BCMCH aims is to become a role model for the other maternal health care units amongst the nearby hospitals. So what we plan for the future. See, our girls are the future mothers. So we need to prime the girls first. So primer of the maternal mental health is by giving that should start at the school level, and it provides a holistic approach to the physical, social, emotional, and environmental factors. So the girls, they should be more considered because they are more vulnerable to mental issues because of biological hormonal influences of puberty and adolescence, and there are pressure issues related to body images, academic performance, social media, gender norms and restrictions, and family dynamics are influencing adults and girls. There can be neglect or abuse in family and parental separation by death or divorce. So there are some proposals kept for this, and we need to increase the adults in school health talks, healthy lifestyles, that is to decrease the obesity, the change that's a non-communicable disease, and approach through physical health issues like stress on the menstrual hygiene, obesity, PCOS, contraception, sexual health, and addressing the hormonal fluctuations and reassurance and strategies to manage mental symptoms, and involving psychiatrist peers for stress management techniques and self-care practices, defense practices. So let me conclude by saying that we obstetricians just not offer the delivery of the baby, but we protect the mother's mind too. So the prevention of postpartum depression begins with the awareness, screening, emotional support, and continuity of care from pregnancy, and it extends through the postpartum period. Thank you.
Thank you, madam. Now I request Dr. Fathima to present her research, which she's currently doing in a hospital.
Good morning, everyone. First of all, I would like to thank you all for giving me such an opportunity. I'm conducting this study as a part of my thesis for the completion of PG course, but more than that, this topic have been assigned by Dr. Patsy ma'am by considering the changes that have been occurring in the maternal death, as we have seen said by the Dr. Arunima ma'am. So the topic for the study is the risk factors of postpartum mood and anxiety disorders. My guide is Dr. Kurula sir and co-guide is Dr. Arunima. Postpartum mood disorders are a group of disorders that can affect new mothers. They include postpartum depression, postpartum anxiety, obsessive compulsive disorders, post-traumatic stress disorder, bipolar mood disorders, and postpartum psychosis. The reduced family support and poor understanding of maternal mental health increases the risk of postpartum depression. Moreover, mental health stigma and social norms in India often prevent mothers from reaching out for professional help. Many cases go unreported as attention shifts from the mother to the baby, causing maternal distress to go unnoticed. The maternal deaths attributed to suicide averaged 7.3% in Kerala during the decade 2010 to 2020 in the third report of Confidential Review of Maternal Deaths Kerala. Majority of the cases of suicide occurred in early antenatal period and did not have any history of psychiatric illness. On a global level, the prevalence of the disorder is about 10 to 15%, and research on postpartum depression has gained momentum within the last few years. Risk factors associated with the postpartum depression has been partially considered in various studies. However, a comprehensive list of risk factors in the Indian context is not available. The need for the study. In Kerala, maternal death due to major causes like hemorrhage, hypertensive complications, sepsis has been reduced over the last few decades. In fourth confidential review of maternal deaths Kerala, second commonest cause of maternal death is suicide. There is 62 cases out of 609 maternal deaths, accounting to 10.2% of maternal death was attributed by the suicide. This clearly reflects the increased generalized suicide rates in Kerala. The difference from other causes is that we are not able to analyze the circumstances and reasons for suicide because the case records are seldom available. The Kerala's Confidential Review of Maternal Death and Prevention of Preventable Maternal Death system has become a model nationally and internationally, and we was successful to bring down the SDG 3.1 to 30 per 1 lakh live births, and the global target set was 70 per 1 lakh live births by 2030. But the rising incidence of maternal suicides is a major concern. When we look into the major cause of maternal death in 2021, if we not looking at the COVID, the hemorrhage and the suicide is almost equal, and the hemorrhage and suicide causes are almost equal in others years also. And the suicide cases over last 20 years is increasing. So initially, Dr. Patsy ma'am assigned me this topic considering all these needs, and we initially planned for doing a trajectory that is considering the starting the study from the antenatal period till the postpartum period, but due to the high sample size and the short duration, we have changed the topic to the risk factors of postpartum mood and anxiety disorders. So the objective of the study is to determine the risk factors associated with the postpartum mood and anxiety disorders. This study is a cross-sectional study conducted over an 18-month period at Believers Church Medical College. The inclusion criteria include postnatal women admitted in the obstetric ward and attending family planning clinic or well baby clinic at BCMCH. And exclusion criteria are patients with diagnosis of intellectual disability, substance use disorders, central nervous system disorders, psychosis, bipolar disorders, pre-existing depression, and critically ill patients and age less than 18 years. The data will be collected from each participant after informed consent during the postnatal period after delivery till 6 weeks, and the data on socio-demographic, medical and obstetric data of the concerning mothers will be recorded on a specially designed proforma, and the postnatal mood and anxiety will be assessed using EPDS, that is Edinburgh Postnatal Depression Scale. The study tools are the socio-demographic and obstetric data is collected with a structured questionnaire. EPDS, it is a 10 contains 10 questions. It is a self-rating scale, and each item is scored on scale from 0 to 3, and the maximum score is 30. A score of 13 out of 30 is taken as a cutoff indicative of postnatal depression with a sensitivity of 92% and specificity of 92%. A validated Malayalam version of the scale will be used for the study. And EPDS 3A, there is a subscale of EPDS consisting of items 3, 4, 5 for detecting anxiety in pregnant and new mothers. Total score is 9 and score of more than 5 is most optimal for identifying cases of anxiety with a sensitivity of 70.9% and specificity of 92.2. The study variables include age, educational status, family type, socioeconomic status, whether she had an arranged or love marriage, age at marriage, occupation of the mother, history of antepartum or postpartum depression in the previous pregnancy, family history of psychiatric illness, obstetric factors like gravidity, parity, number of living children, abortion, stillbirth, birth spacing, whether she had a planned or an unplanned pregnancy, mode of delivery, whether it's vaginal or LS cesarean section, marital status, whether she is married or unmarried, and social factors including conflicts with spouse, preference for male child, perceived lack of social support, and child-related factors, whether she had male or female baby, and duration of the pregnancy, whether it is a preterm, term, or post-term pregnancy, and whether she had any adverse events in newborn, like live birth without neonatal complication or with neonatal complications, stillbirth or deceased, and whether she had a history of NICU admission, whether her baby had a history of NICU admission, and other medical disorders like gestational diabetes, hypertensive disorders of pregnancy, IUGR, antepartum or postpartum hemorrhage, anemia in pregnancy, small for gestational age baby, any mood and anxiety disorder symptoms during pregnancy. And the minimum required sample size according to the statistical calculation is 924. These are my references. This is the Malayalam version of the EPDS scale. And the consent will be taken for the study. Thank you.
Thank you, Dr. Arunima Madam and Dr. Fathima for comprehensively covering the topic of perinatal mental health. Now the topic is open for discussion. We need to just think why in the postpartum period we have so much deaths happening. So we discussed all about the social aspects, but if we look at the estrogen and progesterone levels which drop after the pregnancy, it comes down from 20,000 picogram per ml, that estrogen level, to 10 picogram per ml suddenly, and you have the progesterone levels coming 99% down. So that sudden change in the estrogen progesterone level destabilizes our mood regulating systems, and that is said to be one of the core reasons as to why we have that such vulnerability in the postpartum period. So I just reiterated that along with the social factors which were also described during the presentation.
So Aparna, Arunima and Fathima, thank you so much for an excellent presentation. I'm going to ask you one or two difficult questions. Not difficult to answer, but difficult because raises issues which, one is, Arunima, you said a lot depends on the connect with the obstetrician. Okay. So obviously I love my doctor and I want that doctor to be with me. But when you have different people coming in for the delivery, obviously we are not responding to what you just presented. I know it's tough, but I want us to realize this, because my wife is an obstetrician, I know how tough it is to go every night for the deliveries. But as far as the patient is concerned, the person is concerned, you want the person you love, you trust, to be with you during that most difficult period. Number two is, unless our family support systems, maybe 20, 30 years ago, we didn't even need to discuss this at all. But when I was in Australia on study leave, I heard advertisements on the Sydney radio talking about women who are ready to be mothers. Okay, so they had reached that stage, and I think 20, 30 years later, we are getting there. So unless we make sure that there is enough family support, however much we study all this, and I know that's changing because the kitchens are closed now, the dining tables, there is nobody around them. I think we have to really work hard. Maybe that should be another study that you do, where there is much better family support. The chances of postpartum depression will be much less. But thank you for the presentation and the study. Thank you.
Any questions from the nursing side? Because I think it would be the nurses who would be dealing with the patients in the postpartum period, and Sima sister would have a lot of experience. So, do you want to make a comment or share your experience?
Tanzama's permission. When it is OB-GYN and midwifery, I cannot keep quiet. It is my first love. Two experiences that I had, I would like to share with everybody. One was during my student period, and I had this posting in Wadia Maternity Hospital, and I think that hospital is one of the reasons why I developed this love for OB-GYN and midwifery. And this patient, it was July. It was a very stormy night, and I was just going off duty, waiting for my friend in the NICU to join me. And in the middle of nowhere, we hear this big thud on the windowsill. And when we ran out, I think I've told this story to my nursing colleagues here, ran out, it was one of the postnatal mothers from the postnatal unit who jumped out from the third floor, hit every windowsill, and fell down and broke her neck. And by the time we reached there, she was already dead. Why did I tell this story is because that left a mark on my mind. And secondly, how important it is for us nurses and doctors to assess and catch these symptoms early, the red flags as we mentioned, and how to the hospital environment where they are placed, like the mother MBU that you mentioned in Nimhans. That is very important. At the same time, this Wadia Maternity Hospital is similar to our hospital. The nature is sort of, incorporated into the whole thing. The windows are open. There's no, window, the bars, you can easily jump out. And fortunately, this lady's behavior caught the eye of the senior nursing student. In those days, night duties were managed by senior nursing students. There were no staff nurses there. So that was the part of the curriculum. And so when she was attending, she had kept the baby away from this mother. And she was attending to another patient, and that's when this mother jumps out of the window. That was one incident. The second happened in our hospital. I wouldn't want to name the patient, but she came here with history of all our obstetricians would remember her. And it was with great difficulty that and lot of commitment and dedication that they saved her. Her baby took her to almost term. She delivered. She was admitted quite a few times in the psychiatry unit. The husband was very supportive, very caring. And the hospital, the nursing staff, the obstetricians and the psychiatry team, they had a very close bond with this family. Finally, it was a very happy discharge. They came for follow-up and all that. But the importance of follow-up much after is what I'm trying to say. One day in the newspaper, we see the picture of this lady in the obituary column. She said before she handed over her baby to her mother and went inside saying that she wants to have a bath and come back and feed the baby, and she hung herself. So these things are not something that is happening in other parts of the world or far away from our hospital. It's happening here around us. So as And a long period of my experience being in the Gulf, the predisposing factor was very high there because we saw very women, girls as young as 14, 15, getting married and coming and delivering. We had women who behave very differently when they come for delivery, and when you prod, when you ask questions, probably they would say that their husbands just got married to another girl, which was a big trauma for them. They couldn't accept that. So there are many different kinds of social stress that happens. And what Dr. Suman rightly mentioned is the hormonal imbalance plus the social environment, the fear. I think it was Dr. Arunima who said from the time of conception, let me tell you, it is not from the time of conception, from marriage. Women are under stress because ഒരു 2 മാസം കഴിഞ്ഞ ഉടനെ വിശേഷമൊന്നുമില്ലേ. That is the stress that the society gives them. And then people like me who went through this long period of infertility, the stress that we bear when we face the community is more interested in our well-being. So anganathe karyangal idellam kazhinjecha somebody would have lost their pregnancies, and then they would get pregnant, and the fear of unknown, will I carry this pregnancy to term? Every single movement of that baby is important. So let me tell you, to cut the whole story short, is that labor, delivery, pre and postnatal are not easy part of a woman's life. And the nurses, let me tell you, we catch symptoms, red flags very early. When we hold their hand, when we talk, they'll open up. So I encourage all my nursing friends to help out and be a cardinal role in the team to identify such patients and care for them. Care after delivery, after they go home, is also very, very important. Thank you.
Thank you, madam, for sharing your rich experience.
Hi, I'm Dr. Chitra from Psychiatry Department. So, Arunima ma'am had said about this adolescent mental health clinic for women. I would like to disagree on that because, like you had said, women have time for preparing for a pregnancy, and we know we are going to become mothers. But the fathers are becoming fathers in just one day. It might trigger a lot of men in the audience. I'm saying my apologies for that. But I'm saying we need to educate our young men also. They need to understand what a woman goes through during pregnancy as well as the postpartum period, so that they can be supportive for their partners. It's not just enough to push them into the labor room at the last minute and say, here, take the baby, cut the cord. It's not enough. They become fathers in one day. We take 9 months to prepare, but so we need to educate our adolescent boys, we have seen that even medical professionals, when they become fathers, they are quite unequipped. How do we hold the baby? Is this the right way to swaddle? But the mother is expected to know all of this in one night. So this is my humblest request, that when you conduct the labor clinics or whatever it is, the prenatal classes, it should be mandatory that the fathers also attend. If the fathers are abroad, that is still not an excuse. They should come on Zoom call or whatever it is, because they were there during the time of conception. They should be there during the looking after of the child also. I'm sorry to put it in such a crude way, but that's the honest truth. My mother needs support. So yeah, that's my humblest request to both the psychiatry as well as the...
Thank you, Chitra, for bringing out that very important aspect which was unaddressed. Thank you everyone for your kind participation. We will have our next session of Quest next Thursday at 8 a.m. Thank you.